So that's why it's important to have a structure. So that's why I talk about this following a system. I often practice and talk about the KISS principle, which is keep it simple, stupid. Because we all do very, very complex stuff, and it's very, very important that we don't actually complicate things for ourselves and our patients. So the first thing you ought to do is find a quiet place. If you're in a hub, use a headphone. So if you're in a quiet place, I tend to put my speakerphone on, so it kind of leaves me hands-free, and then I can hear better. At St Andrews, we have a hub system, so we're all wearing headphones. So to make sure that get a good quality headphone, so that you're not getting any of the ambient noise. And it's also helpful if you're not cold calling the patient, just give them a time frame, because have you found DNAs quite a lot when you call someone and they haven't been given a specific time? So what we tend to do at St Andrews is tell them we'll call you between 8 and 10 in the morning, or we'll call you between 12 and 2. So the patients always get a text saying this is the time of call to expect. So it's a time frame rather than a specific time, because you can't promise that you're going to be running to time. So that's the kind of the stage 0 kind of prepping. Now, this is gathering information. I do this with every single patient I want to call, even if I know them really, really well. Which, who's the person, name and date of birth. I'll give you a really good example of a guy at St Andrews I called, and because I had the HbA1c result was about 120 something, and so I called him and then shared the results with him, and he said, "Doctor, I haven't got diabetes." And in his notes, he said he's got type 2 diabetes, and he's on metformin, and he's on gliptin. And so I was thinking about adding a third agent, or giving him a bit of education about diabetes. And he said, "I haven't got diabetes." And turns out, same name, same date of birth. The only thing that was different was the address. But when the patient was booked, I just clicked the wrong patient. So it's always important to just check name, date of birth, does it correspond to the results? So essentially the results have come back into the wrong patient's notes, and then I made the mistake of not clarifying with him when I actually spoke to him, or even beforehand. And always look at what number to call. So one of the thing to do is, sometimes what happens is the receptionist will put on the number for you to call. Sometimes they might write H for home, W for work, or M for mobile. And make sure you're dialing the right number. I have dialed the wrong number and then started talking to somebody, and they said nobody lives here. So I don't know if you ever had that experience. So dialing the number is important. Some of you will work in surgeries where they have systems like Surgery Connect or Babel, where you can actually dial out of EMIS. Some of you will have to dial manually. Today I'm working from home. So what I'm doing is I'm using a system called NYE Health. That's NYE Health. It's a secure system. All you got to do is log in using your nhs.net. So I'm just going to come out of this and I'll share you NYE Health. So can you see this one on my screen? Can you see my screen at all?
No, just the slides.
Just see my slide. Okay. All right. So let me.
You have to change the window that you're sharing. It'll lock to your PowerPoint.
Stop share.
And share, yeah.
And then. So this is what I use, right? So this is called NYE Health. Call a patient anywhere from any device, and it's very simple to log in. And then what I tend to do is copy and paste the number from EMIS directly into it. And then I actually call via the desktop. So it's made life a little bit easier for me. So I'm not dialing the wrong number. And also I'm dialing straight out of there rather than keeping the phones occupied. But you don't have to use it. It's quite useful if you're working from home, and if you don't want to waste your minutes. This is all done via the Wi-Fi.
Another benefit is you get more hits, as in, because usually when you work from home, you use your private number comes up.
Yeah.
But this will show like a number from Oxford or something like that.
That's right, Oxford number. That's right.
Yeah. So usually people do pick up the phone more often than your private withheld number.
Yeah.
But you can't use language line because it doesn't dial 08800 numbers or something like that.
No, yeah, if you're going to use language line, then you've got to use your traditional methods.
Yeah.
It really saves time as well because you're copying and pasting rather than punching numbers in.
Absolutely, especially, yeah, absolutely. Right. You know what I mean by sync the PDS?
No.
Okay. So the next bit is a crucial, always review the notes. Methodically, find a system that works for you. So do you understand what I mean by that? So what is it that we're looking for in the notes?
Recent consultations that they've
Recent
had.
consultations, absolutely. Anything else?
Problem titles.
Problem titles.
Medication, if they're
Yeah,
calling about that.
medications.
Any recent investigations?
Yeah, recent investigations.
Of general context for the problem. So it
Absolutely.
might look like it's a new problem, but then you look and actually it's been ongoing for a while.
Yeah.
What else is going on for them in their health? What might be important?
Yeah, sort of. Absolutely. So one of the things to remember at primary care is, so we don't do transactional stuff. Do you understand what I mean by that? So what we don't deal with problems, we don't deal with presentations, we deal with patients. So if you worked in secondary care, you'll deal with specific problems or specific presentations. If somebody's in a ward, they've had an MI, you're sorting out all the MI drugs, and if they're crying on you, you will tell them, go and speak to the psychologist or go and talk to your GP about it. But in primary care, you're going to get those patients who are crying on you because they're depressed, but you just talk to them about their hemoglobin. So it's always important to remember we deal with patients, not problems. So what that means is you got to understand, who's this person sitting in front of me? Who's this person on the other side of the phone? I think that's crucial in getting to know the patients, and especially in the LTC management. So if you want to understand somebody, always look at the notes. I go through the notes a lot. So I spend probably about a third of the consultation looking through the notes and tidying them up. But a lot of people say I'm a bit obsessed with tidying up coding and everything else. So you don't need to follow that, but just understand who this person is. So it gives you a context. One of the things I do is whenever I talk to anybody, I always ask them what do they do for a living, who's at home with them, and I write that down in the notes. And when I speak to them the next time, I will say, oh, are you still doing that job? And they think I know them really well. I just don't. I've just written it down. And because people are always friendly and nicer to people who actually are interested in them. If you want to make good friends, all you got to do is ask someone else how they are, what they're doing with their lives, rather than talk about yourself. So it's the same thing with the patients. Get them to trust you by showing that you're really interested in them. So any kind of personal nuggets about the patient, I document that in the notes, and I look at my last consultation. You can see on EMIS when your last consultation was, just to remind yourself, and I often kind of repeat that. So as you said, last week consultation is always important, because there have been so many examples where, for example, so say patients call me in July with gastritis, and then I said, go and do the blood test, and then the blood test comes, shows a mild anemia, and then I was going to call the patient, and then I see Maria's got an appointment with the patient the next week. I'll just write in the notes, patient has appointment. And then Maria calls the patient a couple of times. She can't get through to them. And then she documents, try again later or discuss this, because it's slight anemia rather than a significant anemia. And then the patient doesn't come for a while and sees another GP for a different problem, say chest pain. And the GP doesn't look at the previous blood test, doesn't look at the previous consultation. And then 2 years goes, the patient's developed gastric malignancy. Now this is the real case I'm talking about. It's happened. So always important to look at the last week consultation, see what's happened, and make sure that you're actioning anything that might have been left over. And look at the bloods, any scans that they had done, problem list, tidy the code if needed be, medications. You've already given me the answers. And recent documents, have they been to hospital recently? Anything from 111, anything from the hubs? And you can also check Cerner, all records, especially patients are saying that I haven't got an appointment. Even this morning, a patient said, I haven't heard from ENT, and I looked at Cerner and it looked like they had an appointment today. a telephone call, but patient wasn't told. And any kind of care plans they might have. So some of you will use CMC. Some of you might have a separate care plans. And safeguarding, this is crucial. So if there is there any safeguarding information, if it comes up, you know what? Do you know where the safeguarding stuff comes up on the notes on that blue ribbon?
CP, you know?
CP, yeah. If it says CP, have a look at what that's about before you. So this is getting to know the patient before you even call them. I think that's that stage 0 I was talking about. So that's stage 1. So introduce yourself, ID the patient. Do you know what kind of things you would ask when you introduce yourself? So can someone run me through the first thing you say when you're calling a patient? So you dialed and someone's answering. What do you say?
You say, hello, can
Yeah.
I speak to Mr. Such and Such?
Okay, anyone else?
I tend to mention that I'm calling from the practice, and then I say that I'm a practice pharmacist. I'm calling to speak to this patient.
Yeah. So, and can anyone see what the issue, if you're cold calling somebody, for example, what the issue might be with that?
Just from experience, I find sometimes IDing them when you've cold calling them, you get very defensive. So they suddenly think, oh, I didn't know you were going to call from the surgery. Why do you need my date of birth or whatever?
Yeah.
So sometimes they don't know about it and they don't have that trust. Which
Absolutely. So what I do is I say, hi, I'm Dr. Selva, calling from St. Andrews Health Centre. Who am I speaking to, please? So I don't actually ask for that specific person because, for example, say the wife's called and wanted to talk about her vaginal discharge and hasn't told the husband. And then husband answers and then say this, and she hasn't told him that she's gonna be calling us, and then the husband answers, and then you say, can I speak to that? And he will ask, why do you want to speak to her? So ask who's on the other end of the line, and if it is the patient, then just say, just to make sure that I've got the right person, is it okay if I ask you to give me your date of birth? And if you're really pedantic, you can ask for the NHS number as well if you want. Yeah. So it's I would say don't ask for the person straight away. So just ask for who am I speaking to, please. Just ask in a very polite way. And then once you kind of say it's important, your tone of voice. So if you've got about 20 calls waiting to be made, your tone of voice is going to be very different to if you have a bit more time. But remember, most things, so a lot of patients, when we get complaints, the complaints are very rarely about the person's done the wrong thing. It's just the patient feels that the attitude of the clinician wasn't right. And because of that, they will pick holes in whatever you say. So it's not that things have been done the wrong way. That's, of course, we do things wrong sometimes, but it's usually because of communication issues. And that can be because the patient feels that they haven't been heard. So your tone of voice is important, and sense check the patient's emotions. The patient's if the patient's sounding a bit suspicious, then you don't want to raise your voice. You don't want to be sounding rushed. You just need to explain why that is. And then always signpost how the consultation taking place. You tell them why you're calling, and you say, this is what I'm hoping to get out of this. Have you got time? And are you in the right place? Is it a good time for you to talk? So if they're in the bus and you're telling them the chlamydia results, probably not the best place. So it's about making sure there's privacy for the patient, and you say, I'll call them back. And this is where the notes always come in handy. You will have these major alerts in the notes. This patient's always shouting at the reception, or this patient's got this kind of issues. When you get a sense of the patient, if they are quite a combative patient, or if they're somebody who doesn't give you guys an easy time, just make note of that and adjust your tone and your approach accordingly. And the most important thing is, that they feel that they're being heard. So kind of stages 2 to 6. This is where you explore things. You ask open and closed questions. This is the same as, this is no different to face-to-face consultations. A lot of you who've done consultation skills will know this. You ask open questions first, let them talk. How long would you let them talk for? 10 minutes, 20 minutes?
A minute?
Somebody said a minute? Yeah. Anyone want to go higher, lower?
Higher.
Yeah, you can go. I mean,
Go
I
the
wouldn't.
minute.
Yeah, I mean, I wouldn't put a specific time on it.
It
It all
really
depends
depends
on.
on what the question you've asked and whether they have answered the question. If they have answered the question and they're still rambling on, that perhaps maybe interrupt politely and then move on to your second question or explore that further.
How do you interrupt politely?
So sometimes, because it's a lot more difficult, again, as somebody mentioned, because you're not seeing them face to face. So generally I tend to, if they're just rambling on, it's like, oh, okay, sure, I understand. So I tend to have these little words in there, here and there, which kind of make it seem like the conversation that I've asked is drawing to an end and I'm about to move on to a second question. So I was like, yeah, sure, I understand. Okay, sure. All right, another thing I want to, so I tend to kind of lead on from a question to question so they don't just keep going on about the same point.
Yeah. So let's talk. Let's, for example, talk about a patient who's given you, you've asked the open question and they've given you lots of information already, but they're repeating other stuff. So how are you going to say, you need to stop talking now and let me ask the questions? Anyone?
I can see that's important to you.
Say that again, Chandni. I didn't hear that.
I can see that's important to you. And I can also see that X is also important to you. Is it okay if we talk about X for now and we can come back to whatever else is?
So absolutely, kind of one of the things I say is, thank you so much for giving me lots of information. I think I've got a very clear picture of what's going on at the moment, but there are some other things that I really need to check and clarify. Is it okay if I check those? That's when you move on to your closed questions. And sometimes what I would do is, if they're talking, I'll just randomly ask a question that's associated with one of my closed questions. So if somebody's going on and on, just say, are you still smoking? And then just when you throw something at somebody, then it's like, I'm talking now. If you ask me a random question, it's going to stop my train of thought. Don't do it with every patient. There are some patients who've gone beyond their kind of limit of information that you need. You all know who those patients are. They tend to be our regular attenders. The ones who say they can never get an appointment with the health service. So just asking a question, but it's got to be a relevant question to your history taking. So open questions, close, and then probe reflectively. What do I mean by probing reflectively? So exactly what Chandni said. Basically, he said, I can see this is really important to you. So in order to kind of find out a bit more about that, can I ask you some more questions? So that's the kind of the way to do it, rather than saying, you've told me enough, now I need to move on. And then clarifying is, this is where the patient's agenda is, what is it that the patient understands, or what do they actually want from this? And I tend to summarize. I know a lot of history taking things would say you summarize at the end. You can also summarize in the middle. You can summarize anywhere, to be honest, if the patient's giving lots of information. So you can ask, okay, so I understand your son's had the cough for about 3 days and they've got a fever and they've got a cough. Is that right? And then they might correct you. And then you move on to the stuff. So always kind of take the information in chunks. Don't ask, have you got diarrhea, vomiting, abdominal pain, and urinary symptoms? The patient will hear the last bit you said and they'll say yes or no. So if you're asking closed questions, say any diarrhea, any vomiting, any abdominal pain, that kind of stuff. So don't kind of chunk everything, but chunk the part of the history to summarize. And you can paraphrase what the patient's saying. You can actually repeat what the patient's saying. So especially if you're having a mental health patient who's saying they're struggling. So you told me, you haven't been sleeping properly. So then it must be very difficult for you. And then they'll tell you a bit more. So allow them to talk. Do you understand what I mean by silence? Why is silence quite an effective tool? Anyone?
Helps you think.
Helps you think. Yeah. What else?
Allows the person to, gather more questions, I believe.
Absolutely. Have you, when you do the mental health reviews particularly, often the patients don't want to say much. When you do the pain reviews, often the patients don't want to say much. So I'm talking at the moment, and if I suddenly go quiet, how would that make you feel?
Almost pressurized to say something to fill the time.
Exactly. So you'll often hear patients saying, "I don't want to talk much. I'm not in the right mood." So just use silence as a way of drawing them out. So you say something, you ask them a question, and just say, "No, I'm just gonna pause here," and then you just wait. The longest I've done that is about 3 consultations. I used to have this patient who used to come and see me once a month, and for the first 3 months, he didn't really say much. He didn't even look at me. But I kept seeing him for about 3 years. So this was a medical student with autism and personality disorder, and now he's a doctor, and we kind of stuck with it. And the kind of the lack of eye contact, the not saying much, can sometimes be a clue as to, there's something more wrong. So it's don't always give up. And also, because remember I was talking about is patients, not problems. You don't feel like you got to get everything done in one appointment. I know the time pressures, and you got to tick your boxes. It's important. But sometimes with the mental health patients, with the pain patients, it's not always about getting them to do what you want in the first appointment or even the second appointment. Often it's about establishing who you are and who they are, and just having a chat. So with a lot of the patients I'm trying to wean off medication, I actually get to know them first before I even talk about their medications, because it really winds them up. That in the first consultation, you start talking about, we need to cut down your diazepam, which I did 2 weeks ago. And I got a complaint letter last week saying Dr. Selva wanted to cut down my diazepam, because by that I was quite busy, and I just said, look, I can't give you 20 tablets. I'm just going to give you 10. We'll talk next week about cutting it down. And the patient didn't like it, so he put in a complaint letter. So it's sometimes, as I said, we all, when we're pressurized, we'll do this, but take your time. And empowering the patient, always going to get them to do stuff. So locally, we would refer to talking therapies or weight management classes and everything else. A lot of them can be self-referred, so you can get the patient to do some of the job. If they're missing their appointment, give them the central appointments number so that they can book the appointments, rather than actually you calling and finding out what's going on. And then essentially you've got to say what are you going to do for them and what they're going to do, and then you agree the plan. And you end when the patient feels they've been heard and understood. Don't do it for yourself. We've all done it. We've all ended the consultation because it's just getting really annoying now. But try to resist doing it for yourself. After the call, you reflect how that's gone, document everything, because if you don't write things down, you didn't do it. That's the kind of simple way it works medical legally. And then you do the admin. Any questions you want to ask me on this?
The silence thing I've tried on the phone.
Yeah.
I just get like, are you still there?
Yeah. So with some of the patients, I know we're talking about telephone consultations. I think for mental health and the pain management patients, I almost wonder whether a video consultation is much more effective rather than a telephone. So often with my Jonathan, I follow up a lot of mental health patients. What I tend to do is either book a fixed telephone call, and it says so I'm free at that time, or I actually book a video consultation, and then just I can see them face to face at a time. So you agree on a time mutually, and then do the video consultation. It's quite hard actually managing people, especially if you're trying to wean them off pain meds, or if it's a patient you've never met before, you're trying to do a mental health review. So I was wonder whether Sadia, you might want to think about whether is video consultation a better option, given the current climate. Usually you would bring them face to face. I don't think those kind of patients lend themselves well to a telephone consultation, to be honest, unless you know them really well and you've got a defined plan. So what you can do is you can do a video consult with them and you agree a plan with them. And then when you're following them up on a weekly basis to wean off certain medication, you can have a telephone chat. But probably think about video rather than anything else. Any other questions?
Selva, do you not recommend sort of documenting whilst you're on the phone, just while it's fresh in your head?
I do. So I type and as I speak. It's entirely up to you how you want to do it. So if you want to be effective with your time, then it's important that you document as you go along. But okay, some people struggle to do that. So I think it's whatever works for you. So there are three things in my mind every time I speak to a patient. The first thing is, am I being safe? Safe for myself and the patient. So does that mean I'm asking the right questions? Am I following the guidelines, the protocols, and everything else? The second thing is, am I being effective? So if I spend half an hour with each patient, that's not going to fly because there'll be lots of other patients I need to deal with. So in order to become effective, the best thing to do is actually to type as you go along. So one of the things I say to the patient is, you're giving me lots of useful information, so I'm just documenting all of that. So we're not missing anything. So you can use silence to document as well. When we had face-to-face, I would use taking the blood pressure as a way to document while they're typing. But certainly, if you have a headphone or you're on a speakerphone, you can type as you're talking to the patient. Headphones are probably better because they can't always hear the keyboard. The speakerphone, you can hear the clunk sometimes because it picks up everything in the room. So yeah, absolutely. If you're happy to type, especially if you're a good touch typist, then absolutely go for it. Any other questions?
Have you come across any patients where, more so sort of speaking from the long-term condition point of view, where it's like they're not appropriate to do over the phone? And what are you doing in terms of COVID with those patients at the moment?
Yeah, so there are some patients who are being brought in to see our nurses. So if they're coming in for a blood test, or if they're coming for a foot review or something like that, I would just go down and see them at the same time. I'll say, I'll find out what time they're coming. Then I'll just quickly go and make sure that I see them at that time. There are some patients I've got a, if you look at things that are so serious case reviews in out of hours, what tends to happen is usually the patients are told the same story at least 2 or 3 times to a clinician, and somebody hasn't seen the patient. So out of hours tend to have this 3 strikes rule. So basically, if somebody's calling about the same problem the third time, it's best to see them face to face. So I know it's not the best situation at the moment. The COVID cases rising, but the third thing I was going to say is it's about caring for the patient as well. If the patient is telling you the same story and you're not getting to the bottom of it, sometimes just a face-to-face assessment is the best thing to do. And if you can just punch all the appointments in one go, if that's possible, do that. Anything else? Okay, so consultation is the same structure as face-to-face as usual. Now, Aisha was asking me about the diagnostic stuff that we can do. So certainly when you're doing the telephone, you can teach the patient how to take their pulse. If they have a thermometer, ask them to take the thermometer. Some of them will have their blood pressure machine, so do the blood pressure machine. The advantage with the blood pressure machine is it also gives you a pulse as well. And the other thing is, I have taught some patients to measure their respiratory rate. That's a slightly tricky because some patients double count. So what you do is ask them to count every time rather than counting, you ask them to tap. So what they do is every time they breathe in, they tap, and you can hear it. You do it over a minute. So how do you know someone is sick? Someone is sick when their respiratory rate is fast, when their pulse is fast, and their blood pressure is low. High temperature is not always a marker of sickness unless it's a baby, unless it's less than 6 months old. So if you can get a respiratory rate, a pulse, and a blood pressure in a patient, you pretty much know whether you've got a sick patient in your hand or not. So respiratory rate, ask them every time they take a breath in, but ask them not to just artificially inflate it, just to kind of breathe normally, and then tap on the phone. And then the pulse, you can teach them how to take it. If they're struggling, then you can't really do much, but the blood pressure machine is useful. And I also ask them, can you hold the phone closer to your mouth or your chest to kind of see whether they are wheezy, or are they struggling to breathe? And you will also know if they're talking in sentences, you know they're okay. Is there anything else that you specifically wanted to ask me on that?
So thank you for that. It's just like, when I was doing like my diagnostic skills, with regards to, the heart rate.
Yeah.
Like we were taught that, when you're doing their pulse,
yeah,
like in the second half, pretend that you're doing the pulse, but look at their chest so that you can see their respiratory rate, because when the patient knows that you're essentially monitoring their respiratory rate, they kind of change their breathing.
Yes.
So I'm just wondering, if I tell them, look, I'm going to check your breathing every time you take a breath in, tap away. I'm just wondering whether that's going to have an effect on how they then start breathing, if that makes sense.
Yeah, so I think that's where it's important to just tell them, it's just don't change the way you're breathing, just breathe normally, and then just tell me how many times you're tapping. It's initially it'll be quite difficult, but once you kind of keep reiterating to that patient, obviously if they give you, say somebody's got a cough and say the adult's got a cough and they give you a respiratory rate of 30, that patient probably needs to be seen face to face, because that's in a red flag range. And but if they're saying they're coughing but their respiratory rate is about 14, you can relax easy. And also it's a range rather than a specific number, so that's quite useful. So for an adult, it's between 12 and 20. So if it's between that range, so even if they're out by a few, then it's fine. And so to be honest, it doesn't really matter. So because it's a range. But if it's outside the range, then you're going to have other things. So this is where you might want to do a video consultation, and then actually you can count it yourself, or you might need to see them face to face.
Thank you.
So this is quite useful when I do out of hours. This is kind of the stuff. I've been doing out of hours for more than 10 years, and these are the kind of stuff that we tend to do nowadays because we have video consultation. If somebody gives me a reading that's slightly out of range, I just switch to a video. Okay, right. So everybody know what ICE is? Ideas, concerns, expectations, right? So always, by the time you end the consultation, make sure that you've identified what the patient's concerned about, what they're expecting from you, and so on. And shared management plan, do you know what that is?
That the patient also agrees with the plan.
Absolutely. So it's about, is your hemoglobin is 60 and I want you to go to the hospital right now to have an iron infusion. Is that shared management plan?
No.
Yeah, so that's shared management plan. Is your hemoglobin is low, and most people with hemoglobin that low tend to get really unwell, feel short of breath, and can have chest pain. And usually these patients would go to the hospital to have an iron infusion and they will feel better straight away. What do you think? Are you happy with that plan? So that's the kind of a shared management plan. So it's always about, some of our patients do not want that kind of approach. Some of our patients would say, you're the clinician, you tell me. Have you come across that?
Yes.
Why are you asking me? You tell me. That's fine. So they're giving you the authority to take a slightly more authoritative approach. So that's okay. As long as the patient gives you that, rather than you assuming that. And also, it is harder to find understanding acceptance. If you get the feeling that they're not, then just switch to a video or see them face to face. Right. So we all have different ways of doing it, and it's quite helpful to have a framework. So there's something I found. It's called Heron's framework of interaction. So it's a very large framework, but there are some specific types that you can actually use for this. So Heron's framework, and this will be familiar to you. There's something called authoritative, which is basically you're simply informing, you're giving them their results, and then you're making sure they understand it. You send the prescription to the pharmacy, they pick it up, and basically you're saying, this is what you got to do. I don't want you to do that. I want you to do this. We do that often, don't we? So when we're calling about a condition, say for example, allergic rhinitis, and we tell them you go to the pharmacy and buy the medicines, we're being quite authoritative. Now, it can work in certain situations. It can work where you're pressed for time and all you're doing is making sure what you're saying is quite safe. But it doesn't work in a setting where you need a bit more relationship with the patient. So this is where kind of the facilitative approach comes in. So there's the cathartic approach, which is basically patients had a bereavement or they're feeling upset, and this is a mental health patients. So you kind of let them express emotion, their grief, their fear, their anger, without you becoming a punching bag. Now, there's a psychologist called Balint who formulated lots of theories of consultation skills back in the 1950s, and one of his consultation theories is the concept of doctor as medicine, doctor as therapy. So essentially, you are the therapy. So sometimes it's not about giving them a medication. Some patients feel a lot better just by talking to you, talking to someone they know who cares about them and will give them solid advice. And that's usually enough. And especially with these patients who are trying to wean off mental health patients, this is what I meant by establishing that relationship and just talking to them, letting them express their emotions, but be mindful of you taking their emotions on, because that can be very, very difficult to deal with. So think of yourself as a therapist. So think of yourself as the one who is actually, you're not doing therapy, but you're the person who's actually the medicine. And then the other bit is this is the patients whose cholesterol you're trying to improve. This is the patient you're trying to improve their HbA1c. So self-directed them and kind of problem solving, so they need to do that themselves. And also the supportive approach, which is, you know, what is the attitude, what are the qualities they have, can they weigh up the information that you've given them and make the right decision for themselves. So this kind of approach, the facilitative approach, works well for patients you're trying to bring about a change in their mindset. So this is the LTC patients, the patients you're doing reviews on. This authoritative approach probably works quite well for patients where you're just giving out the result, a scan result, and there's a clear plan of action. Obviously, you're going to do this without being very rude to the patient. You're still going to do all the other bits you're going to do. So depending on the types of consultation, change your way from being slightly authoritative in kind of simply informing to all of this. So what are the outcomes of a telephone consultation? So you've done a telephone call. What are the next steps?
Depends on.
Sorry, Dennis, what were you saying?
It depends. It could be a prescription.
Yeah.
Could be advice.
Yeah.
Could be a referral.
Yeah.
Could be. Yeah, I think these are the three main things.
Okay. Anyone else?
Maybe more investigations.
Yeah, investigations. Yeah.
It could be advice from another colleague in the practice.
Absolutely.
Yeah.
I say all of that.
Yeah.
So essentially,
video or bring them in.
So the first obvious thing is you close the call, and then you can consider sending AQRS texts in terms of sending them patient information leaflets. One of the things I've also started doing now is I'm sending them links from medicines.org. So whenever I initiate any new medicines, I'm sending them that link, asking them to read it. Right? You do give them all the side effects and everything else on the phone if you can. If not, just I'm going to send you this leaflet with the medicines information, or the NHS Choices also has pretty much information about all the medications I've come across. You'll know that a lot more than I do. So I send them a text so the patient can't turn around and say, they never told me the side effects of these medications. And I also kind of use AccuRx to signpost about management plans as well. So one thing you can do is if your management plan, you can send it as a text, but treat text like a tweet. Do any of you tweet? So it used to be 140 characters or less. Now they've gone up to 240. Right. So I've seen some clinicians send about 3 texts. Sorry, 1 second. Bit of a cold at the moment, so I've seen clinicians. 1 second. Voice is gone. Yeah, so I've seen them send about 3 texts about all the thought process. It could be this, it could be that. So don't do that. So just send a clear, simple message, and then that's also forms as part of your medical records for the management plan. So if you're gonna send more than a text, or even use more than 250, 500 characters, don't send a text. Just call the patient and talk to them. Convert to video, or you can ask them to send a photo if it's a rash or something like that. And at the surgery, so face-to-face, hot hub, home, or even sometimes emergency department. So if they're saying they've got chest pain going down the left arm, then they need to go into hospital. You might want to refer to district nurse, health visitor, social workers, and so on. So if you're calling an ambulance, don't dial 999. This is the healthcare professional numbers for London. So if you don't have it in your directory, take this number, because it connects you directly to the ambulance station, and they know a healthcare professional is calling. Rather than, because if you dial 999, it will just take you through all the options. They won't know who's calling. This one, they will answer pretty much immediately. And always safety net, and then you plan a follow-up. I'm going to call you in 2 weeks' time. I'm going to call you in 3 weeks' time, or whatever it is that you want to do. Some tips, as I said, always check the patient details. Make sure the patient's there. As I said, if not, just tell them you'll call back. Advocate, interpreter. If the history is a bit sensitive and you're not quite clear who's on the phone, it's a second cousin or it's a neighbor, and you're asking about quite sensitive details, it's best to call back with an advocate or an interpreter rather than using the person with them. And don't ask any leading questions. You haven't got any chest pain going down the left arm, do you? So that's the leading question. And avoid excessive close questions, show empathy, and review the notes. These are things I've already covered. And one of the things I always do is I keep asking questions until I'm sure about what's going on with the patient. This is the way, remember I said about the KISS principle? So when I do a telephone triage, I keep asking questions, and if I don't get the answer I want at the end, or if I don't know what's going on with the patient, I'll do a video or bring them in face to face. If I know what's going on with them, I'll close and safety net, or I might see them face to face in an appropriate setting, or follow up at a later date. So kind of the thing to think about is keep asking questions until you have reached a point where you can reach a successful conclusion, either way, whether it's face to face or follow up. And if you're not sure, just bring them in. This is one of the things that the lawyers and the detectives do really well. So I don't know. Do any of you watch any legal series? You're all working too hard to be watching stuff, aren't you? So if you look at what barristers do, lawyers do in courtroom, they keep asking the same question in different ways. So you'll often find, with some of our junior doctors, so they present a beautiful history to me, and then I clarify with the patient, and they say, no, I didn't say that. It's not that they haven't asked the right question, but they just haven't clarified it. So a perfect example is, I was doing out of hours on Monday. So this patient called us and said, I've got abdominal pain. I've had it for 2 days. And then the registrar kept asking questions about that. And he asked, have you had this pain before? And she said, no, this is the first time I've had it. So it turned out this lady's been having this sort of pain every other month for the last 2 years. So rather than just taking what the patient's saying at the face value, just say, you could explore it by saying, so you're saying that you've never had abdominal pain before. So rather than saying, so in the patient's mind, she thought, she thought the doctor was asking about this type of pain, but she has had abdominal pain before, but it also hasn't been as worse as it is now. So it's always worth clarifying and asking a few other questions in order, until you're quite sure in your head, yep, I'm quite clear about what's going on with this patient. So ask the same question in different ways without annoying the patient. That's it, really. Any questions?
Can I ask something about language line?
Yeah.
They don't automatically give me like their reference number. So, because I know generally when we get people to interpret, they get like a code so that we can recall them if there is any problems. But I'm not getting that from language line. Is that supposed to be happening? As in they're supposed to give you a recall number if there was who you actually spoke to?
There's 2 ways of doing it. Some of them will give you a reference number. Some will ask you for a reference number. So I tend to give the EMIS number of the patient as a reference number.
Okay.
Yeah. So they will have that number on their system.
Okay.
And then they can either connect you to the same interpreter or refer to that patient.
Okay.
Yeah. So you can ask them, if they're not asking, can you just say, can I give you a reference number for your recording purposes?
Yeah.
But no, I wouldn't give NHS number or date of birth or anything like that.
Okay.
Yeah, because EMIS number is quite, because it's just specific to that surgery, and you wouldn't be able to identify with the EMIS number unless you're logged on to that EMIS system. Whereas with the NHS number, you can, if you log on to any NHS system, you can identify the patient.
So I'm not familiar with language line. Is that something that we all have access to?
You should all have access to telephone interpreting service or an advocacy service.
Yeah, no, I'm not familiar. I don't know if everybody else is. Sorry, I'll have to look into that myself.
Yeah, I had a problem the other day. I had a patient, and I think it was from Iran.
Yeah.
And so I had to leave the consultation because I don't know why they booked them with me anyway, and I couldn't go past the first couple of questions, so I didn't know what to do. I just sent message the surgery to see what the next step is, but they haven't replied to me yet.
Do all of you use EMIS or System 1?
EMIS, yeah.
EMIS. So what I would recommend is System 1. So you can do that in System 1 as well. So what I always recommend is, if you come across a patient where they need an interpreter or an advocate and it's not in their notes, add an alert yourself. So be proactive and add an alert saying, always book a double appointment or always book with an interpreter. So the next time is going to save you that issue, and it will save your colleague's issue as well. So
Jonathan, have you found the interpretation service in Barnet?
I have used it, yes.
Can you explain to the others on the call how they do that?
Oh, okay. So individual practices should have their own code, but I can share the general language line contact number. So what you just do, you just dial in. They'll ask you what language interpreter you need. And then what happens is that they'll ask for your contact number just in case you drop off, and the patient's number as well. and they will call an interpreter first. You can speak to the interpreter first to give them a briefing on what you want to do and roughly how long it'll take. Then they will patch, when you're ready, then you can patch it through to the patient.
Can you put that on the WhatsApp group, Jonathan, the number?
Yes, I can do that.
Brilliant.
So that would be specific for the Barnet service. So each CCG area would commission a different interpreting service.
Yeah.
Any other questions?
Hi, can I ask a question about reviews? So if you started a patient for LTC patients on a new inhaler, and you say you'll review in a month's time, and you tell the patient I'll call back, in a month's time, have it reviewed, and safety net, obviously if you have any other concerns before then obviously call back. Is it on your onus to have the patient to call back, or do you have to chase it up? What would you think would be appropriate?
I'll ask the others before I answer that question.
I sometimes book it in if my clinic's up for whenever I want to speak to them.
Generally, we try to.
Yeah, I do the same.
We try to empower the patients. So I would leave, if the patient is responsible, understands, I would leave it to them to contact us. We can't chase all of our 13,000 patients. Unless they're vulnerable, learning disabilities, or I've got concerns that for whatever reason they haven't understood or they're not going to take responsibility for doing that, I would leave it with the patient.
Yeah,
yeah,
so,
I do a bit of both. Yeah, so that's why.
Yes, I would say it's an individual approach. So as Harriet and the others said, it's about how much you think the patient's understood and how much the patient you think will follow what you've said. So if it is quite a sensible patient from your kind of the history taking, and they will follow the instructions, what I tend to do is I send them an AccuRx saying, please book a review appointment in a month's time. Or send an online consultation. So we're pushing online consultation a lot at St Andrews. So about 55 to 60% of our patients actually do it. So on a daily basis, so like in September, we did about 1,700 e-consults for the month. So they can because the advantage with e-consult is they can just send you the information about how they are at the moment. So you could decide whether you're going to call them back or not. So if it's somebody you've started an inhaler, they're sending you information saying, I'm still short of breath, I'm still coughing, then they need a phone call. If they're saying I'm absolutely better, then you can just document that. AccuRx also has what's called a Flory. Do all of you have access to AccuRx? Do you use Flories?
Yeah, I do.
Yeah, absolutely. Yeah, particularly good for asthma because you can get them to do an ACT. You've got the whole score. You can compare.
Exactly.
Yeah, really. Useful.
So they've just developed a blood pressure Flory as well.
Oh, okay.
So what's going to happen with that? I'll give you a bit of inside information. So all of this is being offered for free or on trial basis till April 21, and then all online consultation providers are going to start charging for it. So across London, different CCs are looking at different options to which provider they're going to go with. So because AccuRx already integrates quite well with the EMIS, they will probably be commissioned going forward. So we most likely will have, certainly in I know Northwest London and Northeast London, they're probably going to stick with AccuRx for their text messaging, video, and the Flories. They probably will be going with different types of providers for online consultation. Online consultation, there's about 6 different providers. So there's the eConsult, AccuRx have their own online consultation. The EMIS has their own one, and there's one called Dr. IQ. So there's quite a few different ones. But whatever it is, online consultation and these text messaging and these pathways, Flory type things are here to stay. So at the moment, I'm working with someone called Primary Care Pathways who've developed templates. So essentially, it's very similar to the AccuRx, where you text the template to the patient, and the patient answers the question one by one, and you get the answer straight back via an email, rather than the AccuRx way. So these kind of things are there. So you utilize them for your LTC reviews as much as you can, because it will save you time. And also empowers the patients themselves to do the job rather than you having to do things for the patient. Because, we're here to facilitate health. We are not here to fix people. It's very rarely that we fix anyone permanently. Any other questions? Shall we move on to the coding kind of document issue that Jonathan want to talk about?
Yep. Have we answered everybody's questions, do you think, adequately? That you picked up in your initial sessions? Selva addressed all of that.
Yes.
Could you maybe just tell us a little bit, Selva, about how your system, your telephone triage system works at St Andrews, or whether you have a single list, or do you still have booked clinics, or like how have you made things work?
Yeah, so we used to have a single list. So what we've now moved to is individual lists. So the way it works is there is an on-call doctor supported by 2 trainees who are the on-call support doctors. So essentially, they will deal with anything kind of urgent that comes in on the day. But along with that, all of our appointments open up on the day. So each of our GPs will have 16 appointments. So one's out of that 16 is one's face-to-face, and the other is half e-consult, half telephones. And any appointment that's not taken up half an hour beforehand, they're interchangeable. So a telephone appointment is interchangeable to e-consult. So on a day, if we get more e-consults than telephones, then they'll be converted to the according to that. And then also Maria's appointments. Maria has acute on-the-day medication query appointments, but also SMRs as well. So Maria, do you want to talk a bit about how your appointment looks?
Yes, so I think I briefly touched on it on our previous session 2 weeks ago. So how my appointment looks is in the morning. I have structured medication review slots, which are your patients with comorbidities on polypharmacy that will require a lot longer to review and assess their needs. But those are the slots that get booked either a day before, or if I say, okay, this patient I'm reviewing a patient, I'm thinking, oh, this patient could do with a level 2 or level 3 medication review, then I will book those patients in. And a lot of the time clinicians might be booking the patients in on my morning structured medication reviews.
How long are those slots? Sorry to interrupt you, Maria.
Usually they are 15 minutes.
Okay.
But it varies every day. So not every day will I have patients all fully booked on SMR. Some days I will, some days I will only have 1 or 2 patients. But that is what it does. It separates the afternoon workload. So in the afternoon, then I have slots open for ad hoc queries and e-consults. So anything that is coming on the day and is being booked on the day, so whether it's a medication query, whether it's a problem with anybody's treatment, that gets booked on my afternoon, during the afternoon clinics in this section, which is called the ad hoc queries and e-consults. And a lot of the time, some queries may get shifted to an on-call doctor, but it could be that I can deal with them, then they put it back on my list. Or a lot of the time, if the on-call doctor is inundated with a lot of queries and just can't deal with few things that I can deal with, then again, it gets put on my system.
And along with that, we have what's called a triage list. So once all the appointments are gone, if there are any additional patients that have sent e-consults or wanting to talk on the phone, they go on what's called the triage list. These are routine queries, and our receptionists have been trained to kind of put the appropriate patients in there. So what we would do is, towards the end of the day, if we've managed to deal with our patients, all the ones that have been allocated to us, we might go and dip in and do the triage list. If not, we'll move the patients to the next day. Today, the triage looks a bit busy because I would have been on call normally, and I'm presenting here, and then Kathy's also away. So if we had everybody, there would be hardly anyone on the on-call triage list. And our face-to-face, we have a separate list for our face-to-face patients called clinical assessment list. So you would book the patients in there and then mark down who's seen that patient and whether they're a green patient or a red patient as well. So we know exactly when they're coming. Is that helpful? So one thing we're going to do is we're going to move to a total triage model. We're pretty much there. We're about 60% is coming through online consultation. Total triage through online consultation. That's what we are aiming to.
has that affected the less tech savvy patients?
No, because the plan is what we will have is what's called an e-consult lite. So say if you are a patient who doesn't want to use the tech or you don't have access to the internet, so you will call the reception and then they will ask a series of questions, 6 questions, which pretty much mirrors what's on an online consultation platform. And then they'll just, and it's a template that comes up on emails and they answer it and it's uploaded as a telephone call, but they're giving us information. So the theory is that patient tells us what they want, so we can then signpost them to the right clinician, rather than previously everything just going to one or two people and then us deciding they should not come in the first place. So yeah, so there is a space for people who don't have internet.
Is there a facility for deaf people as well?
Is there a facility for deaf people?
Yeah.
Yeah, absolutely. So the deaf people can of course send the online consultation. Then what we can do is either they will have access to their own advocates, or we can arrange for an advocate through the interpreting service as well. And then essentially you can text them a certain time. This is when we're going to call you. And then have the advocacy service. Or sometimes the advocate will be there with the patient, and then the on-call doctor will just take the call and deal with the problem there and then. So we try and be as flexible as possible. The other patients we try and be flexible is other vulnerable patients. They all have their alert in the notes to say if they're calling, just book them an appointment, a telephone appointment. So they will always get a telephone call. And parents whose kids with developmental disorders, they also get a priority as well. So autism and so on, because they can get quite frustrated with their issues, the children. So we prioritize them.
Selva, I just had a question. So going forward, obviously we're not going to be seeing patients into the winter as much as you would have, I think, this time last year. How do you really pick up on cues for patients that are vulnerable or in a vulnerable situation? I don't know, what do you suggest that you kind of look out for if it's not already in the notes?
I think if someone is being a bit too quiet and not sharing a lot of information or not answering your questions in a way you would expect it to, so those are the patients we've got to be really careful with. So because most patients, you would expect the consultation to go in a certain way. You ask questions and they give you straightforward answers and then everybody's happy. But the ones who are either being quiet and not answering, or they're giving you one-word answers, with those kind of patients, what I would tend to do is I'll say, you've given me a lot of information today, but it looks like you're not ready to share everything fully today. So why don't I book you another call? So there's a couple of patients I tend to follow up regularly, especially teenagers. They're quite notorious. Teenagers with depression, they're quite notorious for not sharing everything. So I've got a few of these. What I tend to do is, okay, it's fine. I'll call you back next week, and we'll have another chat. So you establish that relationship. That's what I was talking about before. So they know who you are, they know you're there to listen to them, and for these patients, continuity of care is important. So the same person calling on a regular basis is much more important than who's calling. And you can be the person, you're part of the primary care team and you're there regularly. So just say, I'll call you in a couple of weeks, or I'll call you next month and we'll have a chat. And then, or you might want to talk to one of the GPs who might know that patient really well and say, it's okay if I ask you to call that patient, because I've got a good relationship with lots of patients, and if you're struggling with that patient, just talk to the GP who sees them regularly. And so that's one of the things we do as well. Any other questions? Sharon, tell me, Jonathan, did you want to?
Yeah, so I know that domestic violence is an uprising thing, and it's very hard to engage it through telephone consultations. I don't deal with these kind of problems at all, but I know that some of us may be encountering this. So I'm just not sure how to deal with if you have those fears.
Has anyone dealt with any DV cases?
We had one at Wapping. I was sitting in with the practice partner. The only issue was that the patient didn't speak English, so we had to use the translation, the line. And the only really issue I had was I couldn't really gauge from the tone how the message was being portrayed. So the questions that the GP was asking were quite direct, but also indirect in a way as well. So they weren't, are you safe? They weren't very broad. They were kind of like, how did you get that bruise on your arm? That doesn't sound consistent to what you're saying. So it was questioning her rather than, I think, really asking, are you safe? Are you okay? You know, are you worried about anything? So we kind of had a huge kind of practice meeting over it because we weren't sure whether it was handled right. And then there was also the issue with, because it was a patient who needed translation or an advocate, it was, how was the message conveyed? So we just had to take it for what she said, and she ended up saying, it wasn't my husband, he's a good man. And we didn't really follow up with it, really. We just kind of left it at that. We had it in the consultation notes. I think there's a way that you could sort of hide it without it being in plain view. I think there was a discussion.
Do all of you know how to hide the notes from online consultation?
No.
On EMIS? Okay, let me just quickly show you that. 1 second. Right, okay, so I'm going to take you to so I'm in Mickey Mouse. Can you see this?
Yeah.
Okay, so I've opened up a consultation. Can you see this one that says online visibility?
Yes.
Yeah, click on that. Do not display. And then so essentially, spoke to patient. So I'm just gonna, and then put the problem title of domestic. And then I will mark it as do not display and then save it. So when you look at the consultation, can you see it's got the computer crossed off sign on the right-hand side? So that means it's not visible if the patient was given an online access, or if a husband managed to get the online access and so on, they wouldn't be able to see it.
And with this one, what if someone asks for like a printout of it or something like that?
So so this is a patient. So anything patient tells us is patient record. So we can't completely hide it from the patient's records. So if they're asking for, what we can do is, so when somebody asks for information, you can always redact it from the notes before you give it to them if you think it's sensitive. So essentially what you will do is you'll just black it out or remove that consultation from the printout they've been given after getting the consent from the patient. Patient's entitled to everything that's in their notes, including anything to do with DV. The only thing they're not entitled to is child protection conference notes. So child protection conference notes do not belong to the patient themselves. They belong to the local authority, the social services. We often scan them in the patient's notes directly for ease of access. But when you're sharing the copy of the medical records with the patient, you always need to take out the child protection details. So whoever gives out the patient notes, that St. Andrews, one of our receptionists is trained to do this. So they will take the bits out. If they're not sure, they'll come and ask one of the GPs, should I include this or not? Okay.
Sorry, can I just ask a quick question? You know the top bar where you put your warnings, etc.
Yeah.
So does the patient have access to that? Because
No.
oftentimes we say things like, well, I haven't said it, but it will say things like angry patient, or treat patient like so, or speak slowly and things like that. So I was just wondering, if they were to request their notes, like for legal purposes or whatever, would they see that as well?
No.
Or?
So the major alerts do not come up. So if I go back to Mickey Mouse again, so anything you add here, so all this bits here, the child protection register, that will come up, but everything else, consent given for son to act on the behalf, that wouldn't come up. And the rest of it, adverse reactions, that will be appearing in a different section anyway, allergy section. So I can go to manage, and then say, if I want to say patient is a fictional character, and then always put down your initials and the date that you put the alert, because some of the alerts become redundant afterwards, and you can just tick whatever you want. You can allow other organizations to view it. So this wouldn't come up in the patient's notes when you give them a printout. Okay, anyone else?
We're running out of time, Selva.
Oh, yes.
So, I mean, I know you're coming back, but Jonathan did have a question about coding.
Yeah.
Jonathan, do you want to articulate that, and we decide whether we can do it in 5 minutes, or whether we bring it back to another meeting?
It's more of the issue is that practice I'm working with, their coding is, let's say, not that, as in particularly the problem titles are not very specific. They're always like lots of admin notes. They like using medication reviews on the problem title, telephone consultations, and hence like lots of medications are not linked to the issue. So when I'm doing prescriptions, I need to look at the patient's notes every single time to find out why they're on this medication, because problem titles are dropped. So I'm just wondering, how would you address to retrain every clinician here to get to a, because I think
yeah. So
well, I've been spoiled by you, so
that's because I'm a bit obsessed about coding and making sure the patients. I mean, the thing is, it's one of the things important for you to remember. So there's no straightforward answer to your question, but I'll start. So general practice is, you're not, as I said, it's not transactional. So basically, you're seeing the patient in their journey that's life. So you might see them for a cough initially, and then that cough might develop into lung cancer, or that cough is just a cold, and then it will just get better. So if you don't record the information accurately, that means the code, the problem title isn't right, and the information about the blood pressure, the pulse, and everything else isn't encoded accurate. It's quite hard for you to actually go through the notes and see the journey that's come up. It's a really good example I showed to all the trainees at St. Andrews. This is the patient I was telling earlier, because this guy has been coming to see us with dyspepsia, and he'd just been coded as dyspepsia, and then a new problem with dyspepsia was added, and somebody decided, I want to call it heartburn, and somebody decided, I want to call it epigastric pain, and then somebody decided, I want to call it reflux. And so it's about 6 different codes over 6 months before we put a code of anemia and then sent him for a gastroscopy. So this happened about 6 years ago.
Hello?
And I still have that patient there, just as a reminder to everybody, things go wrong when you don't document things the right way. And things have disastrous consequences for the patients and their loved ones. So if you're doing medication review, don't put the problem title as medication review, because that doesn't really help. Because I wouldn't know, someone else wouldn't know, or even you wouldn't know of 3 months later, what did you do the medication review for? So what I tend to do is I put the problem title, say if it is diabetes that you've done the review for, I put diabetes, and then the medication review is coded within the comment section or the history taking. So what I'm just going to show you this, what I mean by that. Okay, so for example, we'll go back to Mickey Mouse again. So I'm talking to Mickey Mouse about Mickey Mouse's bipolar, and then I'm also doing the review for the asthma. So rather than choosing a code of the next problem being medication review with patient or medication review done by pharmacist, because if we do that, can you see it's going to be an active problem that's going to remain indefinitely in the problem list, and it will clog it up. You can do the same thing. You can do the same thing in the comment section, right? So that's there. It is coded, so I'm going to save that. And if I want to search for that, I can always go to text search and then search for that. It will come up. Can you see it's come up now? Medication review by pharmacist. Or I can go to investigations. It'll be there. It'll be somewhere in the medical notes that you've done it. So it will be picked up by anyone who's looking into coding. So you don't actually need to put that as a problem title. So put the condition that you're reviewing as the problem title. And if you're doing multiple conditions, just put next problem. And then put medication review done by pharmacist, either in the comment section or in the history, in the examination. It doesn't matter where. As long as it's coded, it will be picked up. Does that?
Or if you did it as a problem, but there's an option to do it not as
administration
active problem, as health administration.
Yeah, you could do that, but it still doesn't tell me whether you've done the medication review for all the medical conditions or what have you done the medication review for?
I usually, if it's me doing it, I will detail what we discussed. If we only reviewed one, I will then clarify in the consult.
But would it link to, say for example, let's see for Mickey Mouse, and you've done a medication review for the asthma, and the problem title is medication review done by pharmacist.
Yeah, by pharmacist. But then, you can do more than one problem. Then I will link whatever conditions I've reviewed as part of that one consult.
Yeah, you could do that. If you're doing that, that's fine. So what you're saying is you're going to say, so I'm going to open it up. Sorry, let's just move this out of the way. So for example, hypertension, and then diabetes. And then what you're saying is you're going to put medication review done by pharmacist, but change that to a health admin.
Yeah.
And then change that to maybe 6 months if you're going to call the patient again in 6 months or 3 months or whatever.
Yeah.
Yeah, and then you save it. You can do that. One thing it will do though is clog up the health admin screen. Imagine the patient's 50 years old and they're going to have medication review done every 6 months for the rest of their life. So it will all be here. So somebody sent me an urgent message. Yeah. So yeah. I think that's a perfectly fine way to do it as well. Whatever works for you. Just don't let this clog up this bit. Can you see like DNA hospital appointment? Shouldn't really be there as an active problem. So when I do that, you go to edit, and then health admin. I might change that to 28 days. The FB22 moved out of area, I probably would leave it there.
Okay, Selva, we need to let these guys go. I'm sure you
do. Yeah.
Sounds like we need another session on this, really.
We do. I think well, because I'm going to do that document coding session, aren't I?
Yeah.
So I'll do that. And
I'll have another look at the timetable, and maybe we can bring that forward.
Yeah. So if perhaps we can do it in November or December.
That's what I'm thinking. I'll let you know. Brilliant. Good. Okay. Well, we need to let everybody get back to their jobs. Thank you very much for being so active in your participation this afternoon. It makes it so much better, so much easier to listen to Zoom. And thank you, Selva, for a great interactive session. Okay, we'll see
thank you, and welcome to all the new team members. It's great. The team is ever expanding. Sharon's interviewing more and more.
Yeah. No, it's great.
Yeah.
Okay.
Excellent.
All right.
Thanks, everyone.
Thanks, everyone.
Thank
Thank
you.
you.
Okay. Bye-bye. Bye.
Bye. Bye.
Bye, everyone.
Bye.